Um, Hello to everybody who's joined us. It's a Saturday night, so I appreciate everybody who gave up their time and to come and learn some emergency medicine. Listen, whoever is on the meeting, you're more than welcome to ask questions. You can ask audio. You can ask on the chat, and whatever is easier for you. It really it's fine. It's not a problem. Uh, Sorry, I'm just trying to set that up. Okay. So at the moment, I think, okay, no, that's fine. It's not a problem. Let's just get that off from there. All right. Okay, so just to start, the reason why I picked this topic is a lot of young doctors that I've seen in the emergency department will very often, diagnose wrist injuries quite easily on an AP view. But once they've got a lateral in front of them, it's just kind of like, oh, okay, that's nice. You know, they gave us an extra X-ray that we can look at, and they put it up. And having overheard some conversations about the lateral X-ray, it's become quite obvious over the years that a lot of doctors are not really sure what the purpose of the lateral X-ray is. So that's what I'm going to try and go through today. And like I say, if there's any questions at any time, you can just put it on the chat, or just put up the hand on Zoom, or just ask. It's no problem at all. I really don't mind. So let's start with the lateral view of the wrist. So I think one of the things that gets to a lot of doctors, number one, the carpal bones are always something that we hate, because it was something that our seniors in university always used to try and catch us out with, name all the bones, name them in order, and everybody hates the carpal bones. They're quite easy after you've worked in medicine for a little while, but initially they can be a little bit difficult. But if you can remember the scaphoid bone and the lunate bone and the capitate, you're actually doing quite well. So this is a lateral wrist X-ray. All right. Now, what I'm going to do is I'm going to show you all of the bones and how they sit and where they are. And we're going to talk about why the lateral wrist X-ray is so important and why missing it is such a problem as well. Okay. So first, let's have a look at this particular diagram here. This actually tells us what we're looking at. So here we see the bottom of a metacarpal. And here we see the capitate bone, which is actually the third bone that's present. We're looking medially to laterally, if I remember it correctly. That's sitting over there. And then we've got the lunate, which sits just next to the scaphoid. Now, if you had to look at these, I'm going to try and draw, but I'm not too good at drawing. So if you were to look at these from the front, what you would get is that you would get the scaphoid here at the bottom. All right. And then you would get the lunate that sits next to it like that. All right. And then just above that, you'd have the trapezium. And then you'd have the trapezoid, right, which sort of sits like that. And then you get the capitate after that. That sits there. And then you get the hamate bone that sits over there. And on this side, you've got the triquetral, which is quite a big bone. And you've got the pisiform, which we see over there, which also sits there. So looking at it anterior to, on an AP view, this is what we're looking at. These are the bones that we can see. So it's quite strange, because you don't really see the trapezium and the trapezoid. They are there, but they are sort of, hidden away. So if we had to look at this, let's try and look at the capitate. So this is the capitate here. If you can follow my diagram, it's more or less there, all right? And then if we look at this is the lunate. Now lunate because of moon, all right? So lunar, lunate, all right? So that's what we're looking at. And then we're looking at the top of the radius. Now, without a doubt, you've got a lot of important bones that sit in the wrist, okay? You've got the scaphoid. You can see the scaphoid sort of sticking out over here. and coming out. But the main ones that we worried about, just change this. So the main ones that we worried about when we're looking at the lateral, the capitate, the lunate, and the radius that's sitting over here. Okay. So I hope that makes sense to everybody. So even though anteriorly, this is what you are seeing, and even anteriorly, the scaphoid and the lunate are probably your most important bones. Laterally, your important bones are your capitate, your lunate, and the top of your radius. Okay. So let's explain what we're trying to find out. When we're looking at the lateral X-ray that we have over here, and you can always screenshot this later if you want. I'm just going to remove the drawings for now. If we are looking at the lateral, what we're actually trying to look for is dislocations. Now, dislocations of the wrist are probably one of the most horrifying injuries that a patient can get off their wrist. The reason being, it often takes quite a bit of work to get that wrist back to normal. Now, let's have a look again. So this is just a hand switch the other way around, okay? And I'm going to teach you another way of looking at it and another way of imagining what's going on. So as you can see, here we have an apple. It's sitting in a cup, and that cup is sitting in a saucer. I want you to imagine that this apple, let's write it over there, that this apple is actually the capitate. Okay, so I'm just going to put a C over there. I want you to imagine the cup is the lunate, and this saucer, this here, is the most distal end of the radius. All right. So we're going to use this as an imagination trick to try and figure out all the different things that can happen. So you've got here this capitate, right, which is equivalent to your apple that we have over there. We have the lunate, which is the equivalent of the cup. So in other words, the lunate is holding the capitate in place, and we have the lunate sitting in the radius, or the distal end of the radius. All right. And just as how the saucer would hold the cup, the radius is also holding the lunate. And just as how the cup is holding the apple, the capitate is held by the lunate. So these three are actually what we are trying to look at to see if there's any sort of dislocations and things like that. So there's a few things that can happen if you have an apple sitting in a cup, sitting in a saucer. The first thing that could happen is that the cup could fall out of the saucer, but the apple remains in the cup. You could have the apple falling out of the cup, but the cup and the saucer remain the same. Or you could have the apple falling out of the cup, and you could have the cup falling out of the saucer. And these are essentially the things that go wrong with the wrist when you are looking at it from a lateral view. And we're going to look at each one of those scenarios, and that's going to teach us about what's happening. So I hope it's making sense so far. I have been told that I talk a bit fast, and maybe if I am talking a bit fast, or if you want me to repeat what's going on, please just let me know, and I'll just slow down and I'll do that. But remember, what we're looking at, capitate, sitting in the lunate, sitting in the radius, which is equivalent to an apple, the capitate, being held by the cup, which is the lunate, which is sitting in the saucer, which is the distal end of the radius. All right. So these three are kind of being held in place. So let's look at what happens when they go out of place, which is what we are looking for on a lateral X-ray. Remember, we're not really looking for fractures. You can find fractures, I'm not saying no, but that's not the primary reason why we do the lateral. And we don't do the lateral just for fun, because very often when there are fractures, you do get dislocations as well. So let's start first with the lunate dislocation. So remember what we said. The capitate, let me draw the capitate a bit better for you here. Just want to get it in the same color. Yeah, I think that red should be okay. So this is the capitate sitting over there, all right? So I just wanted to complete that, all right? And there's the radius. So I don't know if anybody could explain to me what's going on over here, maybe if you have an idea of what a lunate dislocation is. And if you don't, it's not a problem. I am going to explain it. So let's go back one. Let me just clear this out, sorry. Let's just go back one. Sorry about that. So when I say go back one, what I mean is when we talk about a lunate dislocation, what we mean is that the lunate is no longer in contact with the radius. In other words, the cup has fallen out of the saucer. Now, there's two things that can happen when the cup falls out of the saucer. The apple can remain within the cup, or the apple can remain within the sort of the area of the saucer, if I could put it that way. Now, the most common thing to happen is for the cup just to fall out on its own, but it does happen that the apple and the cup fall out together. But generally, a lunate dislocation happens when the lunate is no longer in contact with the distal part of the radius. In other words, the cup is no longer in contact with the saucer. So this is our lunate bone that's sitting over there. And we can see it's no longer in contact with the saucer. Now, in this case, the capitate remains sort of in its alignment with the radius. It's not a major issue if you can't remember the where the capitate should be. The main thing to remember with the lunate dislocation is that the lunate is no longer in contact with the radius. The cup is no longer in the saucer. The apple may still be in the cup, although that doesn't happen. It does happen and doesn't happen. It just depends, on the circumstances. Now, lunate dislocations are quite a problem in terms of repair. The reason being, as you can see, once it moves out from here, and if you could see your scaphoid that's going out over there, it's actually a very difficult reduction because what happens is the capitate, especially if it's out of the lunate, tends to fall down. And it's very difficult to move it upwards, in other words, to get the lunate back into place. So it very often requires surgery for the hand surgeon or the orthopedic surgeon to go in and physically move the lunate back into place and move the capitate into place as well as the rest of the wrist bones. And then, of course, with K-wires and I'm not an orthopedic surgeon, so I'm guessing not with screws and things like that, but more likely with K-wires, try and keep everything in place. If any of you have had the chance to work on these, please correct me because I haven't had a chance to actually do that much of hand surgery throughout the years. I really hated orthopedics, to be dead honest, but I did do it for a little while. But the sound of bone crepitus to this day, it's kind of like nails on a chalkboard for me, that feeling that you get the hair just picks up on the back of your head. Yeah, that's what I get with bone crepitus. So I wonder if you guys could let me know in the chat, does that make sense? Do you understand what a lunate dislocation is? A lunate is just the lunate falling out of the radius. Then we can proceed. In other words, the cup falling out of the saucer is called a lunate dislocation. Even if somebody could give me a thumbs up or something, just so that I know. Okay, there's somebody in the chat. Okay, thank you very much. I really appreciate that. Okay, so right, since we understand that, let's move on. So what we're going to do is that we're going to talk about the intricate blood supply of the wrist. No, I'm just joking. Don't worry. But I just wanted to get on to the rest of it. So now we have something called a perilunate dislocation. So what happens with a perilunate dislocation is that the lunate remains in contact with the radius. In other words, the cup is still in the saucer, but the apple has fallen out of the cup. Okay, just to go back to that. So the cup remains in the saucer. The apple has fallen out of the cup. Okay, so this should be quite easy to remember. Now, lunate dislocations also pose their own real problems. Now, it's both for the patient and for the orthopedic surgeon, although this is generally regarded as a bit easier to fix than a lunate dislocation. The capitate coming out is a very common missed injury. It's one of those where a lot of doctors, and we're not talking about junior doctors here, we're talking about senior doctors as well, picked up x-rays, looked at it, missed capitate dislocations, send the patient home because the AP looks fine. There's maybe some odd, lines that are not measuring up. And as you can see, the patient has quite severe swelling. If you look at the soft tissue over here, the soft tissue is quite swollen. So these capitate injuries, because they're so commonly missed, Patients will go home, they'll sit with it. It's painful. They don't know what to do. They can't move their wrist properly. They'll often attend once, twice, three times until somebody decides to actually send them for a CT or an MRI where it's easily picked up, or they have a radiologist look at the X-ray. And, it's such an easy thing to pick up once you know what to look for. So there you can see the apple, the capitate. It's difficult to see the top of it, but it's more or less still there. So here you can see the apple has fallen out of the cup, but the cup is still in the saucer. All right. So now if we go through it, lunate dislocations, the lunate falls out of the radius. The cup falls out of the saucer. Perilunate dislocations, the apple falls out of the cup, but the cup remains in the saucer. I hope that makes sense. If you guys are happy with that explanation, then we can move on to the next part of it. You can just give me a thumbs up or a yes or a something, then I know that it's okay and it makes sense. There's just one more that we've got to cover, and then we'll just discuss some of the things that go on with it. So I hope you guys are happy with that. Okay, so I'm just going to move on to the next part, unless you have some questions or something that you'd like to know. Now, one thing that I haven't mentioned is, what do you do in the emergency department? Let's say you do find a lunate or a perilunate dislocation. Should you try and reduce it yourself? The answer is no. Very often, these patients do require reduction under sedation or reduction in theater. It's not something that's generally managed by the emergency physicians, even a qualified consultant, prof, whatever it may be. The reason being that there's a lot of ligaments that are also moving around you and tendons that are there and blood supply that's quite, how can I put it, fragile, if I can put it that way. So some of these movements can cause problems. So, for example, trying to reduce the capitate into the lunate can very easily interfere with the arch, the arch that we've got in the hand, and you may well cause entrapment of that. That's why it's very common for it to be done in theater and being done by orthopedic surgeons. So the most that we can do is, number one, identify, and number two, splint. That's probably the most important thing because it reduces pain. Now, a lot of you may say, okay, listen, I'm in the emergency department. Very often, all that I'm doing is seeing things and passing it on to somebody else to actually sort it out. The truth is that, yes, that is very often what you are doing besides resus and trying to, keep people alive and things like that. But if you don't get it right, for example, you don't pick this up and you send this patient home, and let's say there's an artery that's trapped in this dislocation, that patient has the possibility to lose a thumb, to lose a finger. So what we do in the emergency department is extremely important. We are sort of like captains of the hospital. If the hospital was an entire ship, those of us who work in the emergency department and in the outpatients department, we kind of like the captains. We decide where the patients go. So if you see something like this and you send the patient home, the patient is now going to suffer consequences of that. But if you pick it up and send the patient to the correct area, you've actually sent that patient down the right path. You've sent the entire ship down the right path as well. And that applies to a lot of things as well. To give you another simple example, a patient comes in with chest pain and you diagnose pneumonia instead of an MI, you've started the patient down the wrong road already. And if you just diagnose the MI, you've got it right. Now, this is the last one that we're going to talk about. So this is called a mid-carpal dislocation. And basically what's happening with this is that the cup falls out of the saucer, so the lunate falls out of the radius, and the capitate falls out of the lunate as well. Now you may ask me, okay, this looks very similar to a perilunate dislocation. We're going to get to that as well. Now, mid-carpal dislocations and perilunates are very close to one another, and they're often mistaken for one another. And, if you go to as you working in an emergency department, you may go to an orthopedic surgeon or an orthopedic, medical officer and show them an X-ray and say, look, I've got a perilunate dislocation. And that orthopedic surgeon is going to, smugly tell you, no, this is a mid-carpal dislocation. It's not actually a perilunate dislocation. And in fact, it's a mid-carpal type 2, and they're going to give you that smug look of, oh no, this poor child, they don't understand anything about orthopedics. All that you do in that situation when you see that smug look, just tell them, oh, and this is the patient's ECG. I wonder if you could have a look at that. I promise you that smug look on the orthopedic surgeon's face will disappear very quickly. So don't get worried if you get mixed up between the two. But basically, a mid-carpal dislocation, the apple falls out of the cup and the cup falls out of the saucer. I'm very sorry if there's any orthopedic doctors on this. I don't mean to be harsh on you guys. I'm just making jokes, that's all. And please don't tell your orthopedic friends. They tend to be quite strong. They might beat me up. But anyway, so what we've got is a mid-carpal dislocation is the apple falling out of the cup falling out of the saucer, and that's what we call a mid-carpal dislocation. Now, if you want to be let's just look at a summary of these. So this is your normal. You have your radius, your lunate, and your capitate. So apple sits in the cup, sits in the saucer. Perilunate, the apple falls out of the cup. Mid-carpal, the apple and the saucer, or the apple and the cup, so the capitate and the lunate have been moved out of place. And in the lunate, it's the in lunate dislocation, it's just the cup that's fallen out. The apple is still in place. Okay, so I hope you guys understand that part of it. Let's just have a look there. Okay. Yes, that's a very good thing. Yes, yes, a wrist block is actually not a bad idea for these patients, If you know how to give a wrist block, by all means. Now, the only thing with the wrist block, when you are giving the wrist block, you must remember the innervation for the lunate is actually a little bit further down. So if you're working in an area that has, what do you call this? Your nerve sensor, the one with the needle. I can't remember the name of it now. You'd actually go just a little bit proximal to this on the hand. So you'd give your wrist block, and then if it's effective, that's great. But you may have to go up a little bit on the radial and the ulnar and the median nerve. So you might go up to, let's say, about 10 or 15 centimeters proximal to the wrist, because for some patients, especially, you may have what you might call it innervation that's coming from a bit higher up. But if you give a wrist block, definitely it will give you a bit of relief, that's for sure. But the most important thing, of course, would be splinting the patient, and that would definitely help. It's an excellent question, and definitely it will make a big difference. The main thing, like I say, is, generally when you're giving a wrist block, you're giving it around there, around this area, and your lunate, especially your lunate, sometimes gets its innervation from a little bit higher. The capitate, as far as I know, doesn't. But it's a long time since I've done anatomy, and I may be mistaken about the capitate's innervation. But if I remember correctly from the ulnar nerve, it shouldn't have it shouldn't get its innervation from further up. But I think the lunate coming from the radial nerve, you do have another one. It's a small nerve, I think, that runs up, but I'd have to recheck that and just be 100% sure. But excellent question, So if you have if you can remind me what that thing is called, I just can't remember it. The anesthetists normally know this, where you stick the needle in, and it tells you whether the nerve is there, and then you can pump your anesthetic in. If you have access to that, then definitely. Your other option, of course, in an emergency department is, of course, to go quite higher. Yes, a nerve stimulator. That's the one. Excellent, excellent there. Yeah, that's a nerve stimulator. So if you have that, you can go a bit proximally. And if you want to, in the emergency department, of course, we do give brachial blocks, which are quite high up. And that's a bit extreme for something like this because of the possibility of, injury to the arteries and things like that. But, I'm saying a brachial block, sorry, but that's a bit extreme for a wrist injury. But, depending on the patient and the amount of pain that they're in, you could consider that. Although most of these patients will respond quite well to splinting, and they will respond well to analgesia, opioid analgesia, the same as an ankle fracture or an elbow dislocation and things like that. Generally, you don't have to go as far as nerve blocks, but if you have the ability, you know how to do it, by all means give a wrist block. I love giving wrist blocks in the emergency department. They really make a big difference, you know. And thanks for reminding me, Parag, about that nerve stimulator. You're 100% right on that. So just one more for those who are a bit academic. You can, if you really want to know the difference between mid-carpal and perilunate, it tells you exactly what's going on. Oh, sorry, I just made a bit of a mistake over there. So, you know, if you want to later on, you can do a screen grab of this, especially if you plan to go into orthopedics and things like that. I'm not going to get into it because, you know, it's the main thing is actually just to see the clinical features. So as you can see, the mid-carpal is more severe with gross deformity and significant soft tissue injury, because remember, you've got two bones that are now out of place, you know, whereas with the perilunate, you definitely it presents with a less obvious deformity compared to the mid-carpal dislocation. Your treatment generally requires surgical intervention due to the complex nature of the dislocation. Treatment for perilunate managed with closed or open reduction, often followed by surgical repair of associated ligament injuries. The main complication that they're talking about is arterial and ligamentous as well, because you can get ligament entrapment as well, ligament tears and things like that. So generally in the emergency department, which is what we focus on here, we're not really going for complete treatment of your patient. Whereas you in the emergency department can treat a fracture of the radius, a fracture of the ulna, you can even treat finger fractures, things like that. But once you see these wrist dislocations, please make sure that you have an orthopedic on hand. Sorry, this is just a joke to finish off. And if you are in an area, some of us are in areas where we don't have access immediately to specialized orthopedic care, or orthopedic care is a little bit further away, the main thing that you do is stabilize that hand, ensure that there's good vascular flow, you know, check your capillary refill. I mean, there's no arteries that you can feel for pulsation. You can possibly check for the pulsation on the thumb, but that's a bit difficult. And it's also not the best one to check, but you just make sure your hand is pink. That's the most important thing. And then if you have a vascular injury, you make sure that you get that patient immediately to an orthopod or a vascular surgeon, but an orthopod first. And if you have a patient in a very rural area where you have maybe, you know, transport issues, things like that, you splint the hand, even a back slab, even a loose POP, because they tend to swell quite badly, and you get the patient to an orthopod as quickly as you can. If you're working in an advanced setup, then from the emergency department, you can immediately set up a CT scan. That's to make sure exactly what's going on and to look at the ligaments as well. I'm sorry, with an MRI, you can check the ligaments, you can check the soft tissue, and with the CT scan, you can see the amount of displacement, and you can get the exact, you know, movement of the bones and things like that, you know, and then you get the orthopedic surgeon involved. But it's very rare for us to do these types of things. So like I say, the reason for me doing this was that I've seen a lot of our younger doctors just pick up the X-ray, look at it, get this confused look on their face and kind of put it back like, okay, we had the X-ray done, but we don't know what to do with it, you know? So I hope this made sense. I hope this helped you guys to know why we look at a lateral X-ray, and that you'll be able to look at them in the future and be able to judge them as well. Please, if there's any questions, we've still got a bit of time. Zoom sends me a little message now to say there's 10 minutes remaining. I didn't even expect to take that long. But if there's any questions, please feel free to talk or to put it on the chat. It's no problem. And yeah, please remember, don't give your patients bottles that they can't open. It really doesn't help. Unfortunately. And of course, if everybody is happy, then we can end as well. That's no problem too. I don't mind. So I'll just give you guys a minute if you want to think of any questions and things like that. And I can tell you about a patient that recently, unfortunately, had come to my department. When I say recently, I'm not talking about this year. It was actually about a year or two ago, and had one of these, and it was missed. And the patient went through to a private doctor who then sent me the X-rays to show me that, you know, it had been missed. And, you know, unfortunately, the patient did have an arterial involvement, and it wasn't very nice. Now, yes, there are medical-legal implications. Thank you. That's very good. Because what's going to happen is that if these patients are missed, do suffer any sort of arterial blockage, ligament injury, and you have missed it, there's actually very little that you can do to defend yourself based on the initial x-rays, because they will judge you based on what any doctor in your situation would do. So in other words, an emergency doctor working in an emergency department at any level would be expected to know how to read the lateral view of a wrist x-ray. Now, most of us don't. It's not something that's taught to everybody in universities for some reason, despite its importance. If your patient has arterial injury with loss of fingers and loss of, ability to grip and hold, and depending on their occupation, you can be in it for, a lot of money if you're in private, even as a private GP or a private orthopod, although you'd expect an orthopod to pick it up, but as a private emergency physician, you better have your MPS up to date, because it can run into millions if that patient can't carry on with their occupation and things like that. Now, generally, the good part is most of these patients, there's obviously a lot of pain, a lot of swelling. You would suspect something. And the majority of doctors, especially junior doctors, would at least show this to somebody and say, listen, this patient is obvious, there's obviously something wrong. I just don't know what it is. But it's much nicer to be able to go to an orthopedic person and say, listen, this patient has a lunate dislocation. Now, even if it's a lunate and you say perilunate, they laugh to themselves, but I mean, they at least they'll respect you for realizing something was wrong. Or if you say mid-carpal when it's actually perilunate, like I say, just carry an ECG with you. The orthopod will very, very quickly lose any smug look they have on their face. Tell them the patient's hyperkalemic. Uh, they'll say we're not, they don't care about the religion. Anyways, they'll just treat the bones and that's it. Uh, well, it's true, unfortunately. I know some orthopedic surgeon is going to watch my lectures one day and they're going to form a mob, and just come and just beat me up for no reason. They're actually very nice people. They just have this reputation in medicine of being like the frat boys. That's why it's easy to pick on them sometimes. But anyway, listen, I hope you guys enjoyed it. I hope you guys learned something. And please, if you've forgotten anything, you can go back. I should have it up on YouTube in another 10 to 15 minutes. So I hope you guys will enjoy it there. And yeah, I'm just saying, I can't make it out too well what you put over there, but I just want to see it as well. The capsule pumpo grammar guide to aspiring orthopedics. Okay, that is a good one. I'm gonna remember that. The capsule pump. Oh, that is an excellent one. Excellent one. I really enjoyed that one. Oh God. Oh God. That's gonna get you killed by an orthopedic surgeon one day. But anyway, I hope you guys enjoyed that. I hope it was good. On Monday, hopefully we'll go through another ECG, but we're almost out of time. So just gonna end it here. And yeah, thank you so much for giving up your Saturday night to learn something. I really appreciate it. I really, 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 really appreciate it. Thank you for taking your time. Thank you for listening to me. And I hope you learned something. And hopefully we can meet again soon. Okay. Goodbye to everybody.